All right. Hello, everyone. Good evening. So today I'll be speaking about pulmonary edema. My name is Sagar. I'm from fourth year. So, uh, when you're talking about pulmonary edema, these are the things that we're going to cover. So, what is pulmonary edema? And a little bit about the structure so it'll be easy for you to understand. The third would be the risk factors and the etiology. The fourth would be classification. Then we go for pathophysiology. I think if you understand pathophysiology, it becomes easier to understand pathology over here. Complications, diagnosis and treatment, and prognosis. It's not a very big question. It's up to you how much you want to elaborate. But it's an interesting one. So, first of all, what is pulmonary edema? So, pulmonary edema is nothing but leakage of excess interstitial fluid that accumulates in alveolar spaces, which will then result in an impaired diffusion of oxygen from the alveoli into the capillaries. And therefore, the body becomes hypoxic. So, if you look at the structure over here, you can see that. So, this is basically the lungs, right? Here you have the alveolar space. And here, this is the alveolar septa, which forms the wall of the alveoli. Now, if you just zoom into this, right? Over here, you're going to have the alveolar space, and maybe over here as well. And this is the septa. Now you see in this septa, this is nothing but the capillary. Okay. So that is and this is the endothelium of the capillary, right? So this is the same over here. This E that they're showing is nothing but an erythrocyte. So you got an erythrocyte. This is the lumen of the capillary. This is the endothelium. And then you have the basement membrane. This basement membrane is sort of like shared by the endothelium, and on the other side you have the alveolar epithelium. So you have type 1 and type 2 epithelial cells, alveolar type 1 and type 2 alveolar cells, right? So this basement membrane is more or less like shared, and therefore you can realize how easy it is for the gases to diffuse between the lumen and between the alveolar space. So that being said, if there's anything that damages the capillary, or if there is anything that damages the entire structure of the septum, chances are that the fluid from the capillary will leak into the alveolar space, right? It can also be the case where the fluid can get collected within the wall over here itself. So that is between the endothelium, the basement membrane, and the alveolar epithelium. Or, for example, in the spaces between the capillaries where you have some elastic fibers and some other connective tissue, uh, it can get connected over there as well. So um, that's basically the structure. Now, if you look at the risk factors, essentially you divide both risk factors as well as pulmonary edema itself into cardiogenic and non-cardiogenic. So by cardiogenic, I mean cardiogenic factors, right? For example, left side heart failure, mitral valve stenosis, volume overload, high systemic blood pressure. Now, how do these actually cause pulmonary edema? Will be covered in the pathophysiology part of today. And similarly, we have the non-cardiogenic risk that includes like infections, breathing noxious substances, septicemia, hypoalbuminemia. Again, how do these cause pulmonary edema? Will be covered soon. But essentially, non-cardiogenic risk factors means all those risk factors which directly damage the septa, whereas cardiogenic is something that damages the capillaries or there's some sort of a pathology within the capillaries, and that will lead to pulmonary edema. So again, you have either a direct damage to the septa or you have something going on within the capillaries which will then cause the pulmonary edema to develop. Right. So again, the classification of pulmonary edema can be based on its underlying cause. So you got cardiogenic and non-cardiogenic pulmonary edema. Um, and we can also define it based on the severity of the pathology, like whether it's mild edema, severe edema, etc., and anywhere in between that. But I think it's more important to stress on cardiogenic versus non-cardiogenic. Now, um, so if we consider the pathophysiological mechanism, we can see that, one second, yeah. If we consider the pathophysiological mechanism, again, you can look at the definition. What's happening is you have leakage of the excess interstitial fluid, or rather the fluid from the capillaries going into the interstitium, and then from the interstitium or within the septa into the alveolar space, right? And once it reaches the alveolar space, the fluid is covering the membrane, right? And that's why there will be reduced permeability of the gases through diffusion. Now, when we talk about the cardiogenic causes, uh, we spoke about left-sided heart failure, mitral valve stenosis. We can also speak about volume overload and pulmonary hypertension. Essentially, when there's increased hydrostatic pressure within the capillary itself, the fluid will be forced to go out of the capillary and within into the septa. And then if it still gets loaded, then it goes into the alveolar space. So increased hydrostatic pressure. The cause of this could be left side heart failure or mitral valve stenosis because basically there will be a backward flow of pressure from the left side of the heart back into the lungs, and that's why there'll be increased pressure within the capillaries. And this is nothing but the pulmonary hypertension that we speak about. And similarly, when there's high systemic blood pressure, for example, so again, the pressure is transmitted backwards from the aorta into the left ventricle to the left atrium through the pulmonary veins and into the lungs, right? So again, you're increasing the hydrostatic pressure. So the main thing with cardiogenic pulmonary edema is that there'll be a hemodynamic change, and more specifically, there's going to be some force, increased hydrostatic pressure, that is going to push the fluid into the septa and then into the alveolar space. All right. So, no, non-cardiogenic. So you have infections or some noxious substances which will directly cause injury to the septa, right? And that will result in inflammation. And we know that in inflammation, there's increased vascular permeability. Therefore, the capillaries will be more permeable, and therefore the fluid will then get accumulated within the septa. And then again, if there's too much of damage or too much of accumulation, the fluid from the septa goes into the alveolar space. You can also have indirect injuries such as septicemia and drugs, again, which eventually will lead to damage to the endothelium, increased permeability, and then into the alveolar space. Now, non-cardiogenic can be hyperalbuminemia. So essentially within the capillaries, when there's decreased amount of proteins, there is no oncotic pressure, which is pulling the fluid back into the capillaries, right? So the fluid will be more, it's more likely that the fluid will get attracted to the proteins in the interstitial space, that is within the septa, than the proteins present in the capillaries. So some causes of hyperalbuminemia could be nephrotic syndrome, liver diseases. So you can just mention liver diseases and nephrotic syndrome, to be honest. And of course, malnutrition is quite logical. And then lymphatic obstruction. So why exactly is lymphatic obstruction the case over here? So I'll explain that to you in a moment. But essentially, lymphatic obstruction can occur due to a tumor or some infection, or it could also be due to like tumors in the pleural space, some mesotheliomas, etc. Now, um, yeah. So for lymphatic obstruction, the reason why this is a cause over here is because obviously when there's lymphatic obstruction, I can show it to you over here actually. I think I would have it. Yeah. So you see, typically what happens is the fluid, if you look at the hydrostatic pressures and how they change, you have a capillary hydrostatic pressure and you have got the interstitial hydrostatic pressure, right? The interstitial hydrostatic pressure is nothing but the pressure within the septa itself. Uh, so the hydrostatic pressure from the capillaries is obviously more, right, than the interstitial hydrostatic pressure. However, when you look at the oncotic pressure, the capillary oncotic pressure exceeds the interstitial oncotic pressure. Okay, and also the hydrostatic pressure. Sorry, yeah, and also the hydrostatic pressure difference between the pulmonary capillaries and the interstitium. If you compare that, and if you compare the oncotic pressures between the interstitium and the pulmonary capillaries, you will realize that there's more fluid that is getting pushed into the interstitium, okay, 15 to 20 mLs per hour approximately. And now the fluid is accumulating in the interstitium, and you know that if the fluid has nowhere else to go, it's going to accumulate further in the interstitium, or that is in within the septa, and then it's going to get into the alveolar space. So how is this fluid being removed? It is being removed by precapillary lymphatics, which keep the lungs free of excess fluid. So when there's a tumor or when there's some lymphatic obstruction, the fluid is not going to get removed, right? And therefore, there'll be fluid accumulation within the lungs. Now, just a second. So, just going to highlight this on this one. Right. So, if we go back, and hence the reason for this lymphatic obstruction being present in as part of etiology. Now, like I've been mentioning since the beginning, the fluid, when the fluid in the vasculature exceeds the capacity for fluid clearance with the lymphatics, the fluid will get accumulated within the septa, right? So, to be more precise, the first accumulation will occur in the peribronchial interstitium, that is higher up to the hierarchy when it comes to the division of the bronchi. And then the bronchioles are going to get quite distended. And then naturally, the fluid will accumulate further down to the hierarchy around the alveolar septa, right? And final stage is that the fluid will leak from this alveolar septa into the spaces. So now let's look at the pathological picture. So this is the pathology part of this question. So in cardiogenic pulmonary edema, the fluid accumulates in the lower lobes because the hydrostatic pressure gradient is from the top to the bottom, where the bottom is it's the highest. And obviously, if the fluid accumulates within the lungs at the bottom part, you're going to find obviously more fluid in the alveolar spaces. And this it becomes very heavy, and also you're going to see bubbles of water. So the weight will be like 1.5 to 2 kgs or higher or lower compared to the normal 250 to 300 grams. So if, for example, you get the chance to press a lung from a cadaver which is filled with fluid, you can see bubbles just oozing out, right? Bubbles of fluid oozing out. That's typically what's happening inside the lungs in someone who has got pulmonary edema. Also, because of the damage to the capillaries, you're going to have some RBCs leaking into the interstitial space, that is, into the septa, and naturally into the alveolar spaces as well. So, macrophages will try to destroy it. They will become RBC-laden macrophages. They'll be brownish in color, and obviously, the way a damage of the extracellular matrix gets solved is through fibrosis, and therefore there will also be fibrosis of the septa, right? So fibrosis, thickening, plus the macrophages. These three together will cause this brown induration and hardening. Now, microscopically, again, you'll see a lot of RBCs because of the collection of fluid or the stasis of blood. Because when there's increased vascular permeability or when there's increased hydrostatic forces, there's more fluid being pushed. And essentially, when there's vascular diameter increase, there can be stasis of blood. But it's also important to know that there is this reflex where the pulmonary capillaries actually constrict when there's excess of fluid coming into the lungs. Uh, so that's just a pulmonary reflex, I think that's what it's called. So just look more into that, and I think it's a very interesting topic. All right. Now, the macrophages are basically called heart failure cells. And let me correct myself. It's basically RBCs are destroyed in the alveolar spaces, and whatever hemosiderin is coming out of the RBCs, that is going to get like eaten by these macrophages, right? So it's hemosiderin-laden macrophages, not RBC-laden macrophages. That's my bad. Apologies. Now coming to the non-cardiogenic pulmonary edema. So you see how because cardiogenic is not technically inflammatory source, there's usually a transudate that fills the alveolar, and it's obviously pink in color because of RBCs and like the hemosiderin. But in non-cardiogenic, when there are infections, there's usually an inflammatory exudate, right? So this is very important, and that's why I labeled it in green. Here's exudate, here's transudate. Um, and of course, like pneumonia is typically a bacterial infection will result in pneumonia, and the end result or the further progression of pneumonia can be ARDS. So essentially, if you look at this picture, you have some edema, right? You'll have some collection of mucus. Naturally, there'll be inflammation, so there'll be edema over here. but you see it's more towards the base. However, if the disease progresses, then you can see that there's diffuse edema, and also there'll be some mucus collection depending upon the pathogenesis. So there'll be edema, and that's why it's more, let's say, opaque. I mean, sorry, it's more like whitish in color over here. So yeah, so that's basically the disease progression from pneumonia to ARDS, and that's why ARDS here there's diffuse edema, pulmonary edema, over there, and for pneumonia it's more or less localized, that is over here. Okay. Now, how can it be prevented? Well, under normal conditions, the mechanism responsible for preventing the edema is basically the Starling hypothesis, which I've just mentioned earlier. Other than this, you can treat pulmonary edema, you can diagnose it early, you can prevent the infection progression, you can detect the pathology earlier, and you can provide adequate treatment. So, how do you treat this? Well, you can provide supplemental oxygen because the body will be hypoxic. And if there's cardiogenic etiology, you can boost the heart performance so the heart starts pumping more. Like there's something called as inotropics in pharmacology. They can sort of help in boosting the heart performance. And also you have non-cardiogenic causes such as inflammation, pneumonia, etc. So you can manage this through antibiotics and other medications. And if there's low on-cortic pressure, let's say, for example, due to hypoalbuminemia, which I think is more or less to the cardiogenic etiology, it can again restore protein concentration in the blood. So there are many other different mechanisms for, or rather protocols for managing the illness. Now, what are the complications? So again, like I mentioned earlier, you have pneumonia, which can proceed to ARDS, which is diffuse pulmonary edema, right? So ultimately, it's actually ARDS if it's left untreated or if the edema progresses further, and this could also result in death. But if you start from the early stages of progression, right, usually the gas exchange becomes difficult. There'll be hypoxia, there'll be hypercapnia, so there'll be the person will try to breathe quicker and faster because they're not able to get oxygen, and also they have to breathe out carbon dioxide because there's hypercapnia, right? And then there'll be shortness of breath because they're not able to, the lung is not able to expand and contract properly. And of course, they have to breathe faster. So together there'll be shortness of breath. And also, when there is some left-sided heart failure, for example, more blood goes into systemic circulation into the heart and therefore into the lungs because you're lying flat. So you have redistribution of fluid. And so there'll be more chances of the blood just collecting in the lungs. And this can also result in the shortness of breath when lying flat. Um, yeah, that's pretty much it. So there'll be dyspnea, shortness of breath, difficulty in breathing, difficulty in sleeping, um, maybe higher respiratory rate temporarily, etc. Now, what is the prognosis in general? Depends on the patient. If there's a mild disease but the patient is immunocompromised, then it can quickly progress into ARDS. If let's say the patient is quite healthy and he or she has got a strong immune system, uh, the pneumonia can get resolved with adequate medications, right? And also the medications need to be provided on time. So that's pretty much it. So just to conclude, you just speak about what is pulmonary edema. Just remember the structure of the septa. And until now, whenever I say interstitial spaces, I mean this region over here, this region, or within the alveolar epithelium, within the basement membrane, within the endothelium. So that is the interstitial space. This is the capillary and this is the alveolar space. So the fluid is from here, it gets collected over here, and then if it's not going to get drained by the lymphatics, it will then go to the alveolar space. So you speak about the pathophysiology, remember cardiogenic versus non-cardiogenic. Complications, end result is ARDS. Before that, you can sort of depend on logic to understand dyspnea, explain shortness of breath while lying flat, etc. Diagnosis and treatment, prognosis, I think it's very simple for this question. So, yeah, all the best for your exams. Thank you. Okay, so sharing.